You already know why your patients need to stop smoking. Obviously, it's a hugely important thing for their health. You probably also know that quitting is very, very hard for patients, and most patients feel like they can't quit. They may have tried unsuccessfully, they may have quit for a short time and come back to it. You may not know, however, what you can do to help. It's so important that you, as a healthcare provider, take an active role in bringing up the issue of smoking cessation and giving patients practical tools to help them quit smoking, because you can really make a difference. It turns out that there are several medications that are FDA approved and proven by research and clinical consensus with lots of practical experience behind them that are safe and effective to help patients stop smoking. The first broad category is nicotine replacement therapy, sometimes abbreviated NRT, and then there are also two anti-craving medications, Bupropion, brand name Zyban or Wellbutrin, and Varenicline, brand name Chantix. Nicotine replacement therapy comes in a variety of delivery systems. You probably know about patches in a variety of strengths, once a day transdermal delivery of nicotine with a smooth, even blood level, and then a variety of intermittent PRN, short-acting nicotine delivery systems, gum, nasal spray, inhaler, lozenges, and more recent on the scene, electronic cigarettes. The mechanisms by which these medicines work are very interesting. You know that nicotine replacement therapy works by delivering nicotine in a safer form. It's the other products in tobacco that are so dangerous and have health consequences. So nicotine replacement as a safe substitute helps with withdrawal, reduces craving, and allows patients to taper down gradually in an even way so that they're less likely to quit. Varenicline is a partial agonist, partial antagonist at the nicotinic receptor, so it both reduces cravings, reduces the effect of cigarettes at the receptor, and helps reduce reward. Bupropion works by boosting dopamine in the central reward pathway so that patients get less pleasure and are less likely to have their intrinsic reward systems hijacked by nicotine and other addictive substances. So here are the basics of how to use these medicines. Step number one is to talk to patients. Even before using medication, it's get them going, try to enhance their motivation, and what you should do is try to establish the personal link to their individual health situation and health outcomes. It's all good and well to talk to them about the possibility of cancer in 30 years, but even more important and more salient for your patients are the immediate health consequences for right now. What's the trouble with your breathing now? What's the trouble with your exercise tolerance now? Can we improve your blood pressure today? Can we improve your sexual function and erectile dysfunction if you cut down your cigarette smoking now? And then keep going with motivation as long as it takes until you can get patients from pre-contemplation to contemplation into action where they're really willing to do something. Once they're willing to do something, now you need a plan. The first thing to do with a plan is to set a goal. Often the best way to set a goal is to get out a calendar and get them to help pick a quit date. That's the date that they're willing to say, I'm done, I'm going to try to stop, go to zero. And in a self-directed way, they try to cut down between now and that quit date, but the quit date is the date that they've really selected. That can be tomorrow, that can be next week, that could be their birthday, that could be New Year's, but it helps actualize their energies towards a goal. Give them anti-craving medications now. Write the prescription now. It helps actualize the plan, but tell them that they should start those medicines several weeks before that quit date, and that right around the quit date, as they're starting to have some tobacco withdrawal, some nicotine withdrawal, they should start nicotine replacement therapy. Now, there has been a lot of concern and a lot of discussion about some of the barriers and difficulties to using NRT. Over the years, we've really discovered that it's far easier than many of you may have thought. First of all, we've discovered that combination NRT is more effective than monotherapy NRT. That means you can combine long-acting delivery systems like a patch with short-acting delivery systems that the patient can take throughout the day when they want a spike of brief nicotine in their blood system, the gum, lozenges, spray. So that's more effective when together. It's okay if you continue an extended duration of NRT. We used to talk about weeks. Now we realize that months is more effective, and even an indefinite time in which, if it's helpful, keep it going. And you can even start patients on NRT before they quit while they're cutting down, and not be afraid that they'll smoke on top of it, because it will help accelerate their cutting down and help accelerate their quitting. Now, the next level up after the basics is that if you have the time, more monitoring is better. The longer you use medications, probably the better, and if patients lapse or relapse, resuming medications is helpful for them. To the extent that you have office resources or collaboration to be able to provide counseling, whether that's by specific dedicated counselors in your office, or whether you refer patients to telephone quit lines, which are available in many places, or a variety of convenient online resources which can give them support. The more frequent you can talk to them, don't need a lot of time, just a couple of minutes, checking in, how are they doing, encouraging them, debriefing them about their successes and failures, and endlessly praise them. Encourage their successes, even if those successes are small. Cutting down, even short of full abstinence, is definitely associated with beneficial health outcomes, and the more they try, the more likely they're to succeed. Reframe the issue of having to have multiple quit attempts. It's not a failure, it's practice for future success. Each time you quit, you hope it sticks longer. For an even more advanced approach to the use of smoking cessation medicines, one way is you can start the medicines, both anti-craving medicines such as Varenicline or Bupropion, right away, not waiting for a quit date, and start NRT right away, not waiting for a quit date. And in that way, consider partial quit attempts, or quit sampling as it's sometimes called, as a way of improving efficacy towards a future quit date. Again, I mentioned combining long-acting NRT, that is a patch, with short-acting NRT, gum, lozenge, or spray. That turns out to be more effective than monotherapy. And something that's gaining ground and has some increasing data behind it is even the combination of anti-craving medicines. So instead of choosing either Bupropion or Varenicline, try one and add a second. Or for your very high severity smokers, start with both. It turns out, and I'll show you this data, if at least in one or several trials, it turns out that if you add Varenicline to Bupropion, it's better than Varenicline or Bupropion alone, with longer 3- and 6-month outcomes for quit rates. Although both are better than placebo, individually, both together are better than either. Talk about some special populations that are high risk and especially difficult to manage. Smoking in pregnancy is particularly bad, not only for the patient, but for the unborn fetus. Although these medications do not have as much data as we would like for safety and efficacy in pregnancy, there is a broad clinical consensus that Bupropion and NRT are safer, certainly safer than smoking, and that's the appropriate combination to use in treating pregnant women. Psychiatric comorbidity is a very important special population. The rates of smoking among patients with persistent and serious mental illness, depression, anxiety, schizophrenia are way higher than in the background population, so we need to target these populations. It turns out that outcomes are worse both for smoking cessation and for the other drugs of addiction, so it's important to be aggressive and to manage this in a consistent and persistent way. One of the things that is important to try to remember to do is also aggressively treat the comorbidity. So reducing symptoms of depression and anxiety will help overall with smoking cessation efforts. There are some side effects that need to be considered. They are less severe and less problematic than perhaps at first thought. With both medicines, we sometimes look for depression, irritability, or other psychiatric side effects. But those are things that can be managed, and a little extra monitoring goes a long way. Especially important to remember that it's the withdrawal from nicotine that seems to worsen depression. So if you aggressively manage withdrawal, you probably go a long way towards alleviating side effects. There is some controversy in the field about the appropriate timing of smoking cessation for patients who have other addictions. That is, on the one hand, should tobacco cessation be considered an essential part of the basic addiction treatment package? Got to do it now, got to do it all at once. Or should it be postponed because patients say, I've got enough on my plate quitting alcohol, quitting heroin, I can't deal with that now, one thing at a time, give me time. We don't have the data to answer that question, but we do have clear consensus that tobacco use worsens addiction treatment outcomes, that other comorbid addiction worsens tobacco cessation outcomes, so it's really important to address this. Whether it's now or later, it needs to be done aggressively, as soon as patients are willing. This is an important part of treatment. Another bad reputation that smoking cessation gets is weight gain. Patients are often more afraid of this than you know. The average weight gain is only 4 pounds when people quit, but there's some skew, and 1 in 10 have a really significant larger weight gain. This is a major concern and often turns patients off. Withdrawal is probably the biggest reason for increased appetite and weight gain, so if you manage withdrawal aggressively with NRT and other mechanisms, you can probably reassure patients and get them to go the distance. Another special population that's particularly vexing is young adults and adolescents. Unfortunately, we have very little success in adolescents. The data for nicotine replacement, the data for anti-craving medications has been disappointing. Adolescents in general are complicated and hard to treat, and I know that that shocks you, but that doesn't mean we shouldn't keep trying. It's really important. The earlier you intervene, the more likely you are to have success in any behavioral risk. And young adults, which are a sweet spot, I think, the 20-somethings and 30-somethings, which are a sweet spot in our ability to get patients to change. We do have convincing data as part of our adult trials, so definitely press on with that population. To conclude, it's important to remember that your patients can get better and you have a big role to play. If you will talk to patients about smoking cessation, you'll find it's much easier than you may have thought. It's remarkably effective. The use of smoking cessation medicines are a very essential part of the standard of care and should be routine in everyone's practice. Ask patients, give them encouragement, give them medications, because patients can quit, but in order to do so, they need your help.